Okay, let's go ahead and get started. So let me go ahead and get started. This discussion is on the Mesolimbic pathway. And specifically, we're going to talk about the effects of PCP and LSD. Let me just take you through some of our earlier discussions here. First, we here in our discussion on these pathways, remember we looked at this mesocortical pathway right here. And this mesocortical pathway, when it's injured, basically before puberty, it results in symptoms that consistent with autism, right? However, after puberty, when this network is damaged, we can see hyperactivity results in symptoms that are consistent with positive symptoms of schizophrenia, and hypoactivity seems to be associated with negative symptoms of schizophrenia. And we went through the receptors located on this nerve bundle. And this nerve bundle is primarily innervated by dopamine neurons. Also, remember, they have glutaminergic neurons on them, glutaminergic receptors on it. Remember, they also have, I believe, serotonin receptors on them and norepinephrine receptors on it also. Excessive glutaminergic activity can really excite this nerve bundle, and you'll see positive symptoms of schizophrenia. Later in our discussion, we moved our attention over to this other very important network, the mesolimbic pathway. Mesolimbic pathway, and this is sort of like the reward and learning pathway. And remember, this is the target for substances that are used in abuse, for substances that are abused. This is the primary target. Hyperactivity is associated with symptoms that people want that's associated with intoxication. And hypoactivity in its network, typically dopamine depletion and withdrawals. We went through cocaine and the impact that it has on this system, causes the release of presynaptic dopamine into the synaptic cleft and results in increased transmission along these dopaminergic neurons, therefore making them hyperactive. And it comes from the vesicles that are stored presynaptically, and those vesicles dock and they release the dopamine into the synaptic cleft. But once all the presynaptic dopamine is gone, there's nothing else to push out into the synaptic cleft. And so now we have a situation such as withdrawals, and such the network is hypoactive. We also looked at the impact that ecstasy has on this pathway. Again, ecstasy, I keep getting the nomenclature, MNDA, the name of ecstasy, and it activates NMDA, which is a type of G protein, type of glutamate G protein. So ecstasy activates glutamate directly through the MNDA as its receptor, as a target. The problem with ecstasy is that the activation of the glutamate leads to overexcitation, and you risk the cell dying, sort of right until the wheels fall off. And that's one of the characteristics of ecstasy that concerns me. And so I always make sure I do some degree of neuropsych testing on these patients to document their memory function and see how their hippocampus and memory is functioning. You also want to see how their prefrontal cortex is functioning, to see if they have access to abstract reasoning. And you also want to look at their frontal lobe to see if they're able to, if they have some degree of executive functioning, meaning they're able to go make a coherent plan as they engage with the world. So ecstasy really damages the brains and all those circuits because it targets glutamate, overactivity leads to death. And so ecstasy users, as well as methamphetamine users, can experience a lot of deaths associated with this excitation process. And that damage can continue to progress in the future. I'm not sure how much it continues to propagate in the future. But I know in the case of traumatic brain injuries, you may not get any damages, pick up any damages currently, but after the death of the process continues, you can pick up the deficits maybe at 10, 15 years later. So let's look at PCP, okay? And so let's see, I think I'll just go here, and let's see here, okay, okay. So next on PCP, okay? Look here. PCP is primarily exerts its effect by acting as a non-competitive, it doesn't have to compete for the site, on the NMDA receptor. Yeah, here's the breakdown. The NMDA receptor antagonism, PC binds to a specific site within the ion channel of the NMDA receptor. Now remember, this is a glutamate, so it's a type of glutaminergic receptor. Normally, NMDA receptors are activated by glutamate, leading to an influx of positive ions and depolarization. Oh, PCP blocks this ion channel, preventing the flow of positive ions into the cell, inhibiting neuronal depolarization. This doesn't sound good. This disruption of glutamate excitation activity is thought to be responsible for the anesthetic, analgesic, and dissociative effects of PCP. Yeah, every time patients come in with PCP, they have the hallucinatory experiences and things like that. And it says NMDA receptor. And I guess the way it operates opposite, it shuts it down. Additional, beyond NMDA receptor antagonism, PCP also affects other neurotransmitters. Oh, okay. Inhibit dopamine, norepinephrine, serotonin reuptake. It also acts on receptors, those opiate receptors, muscarinic receptors, nicotinic, and GABA. The GABA receptors again. Let me go back to the Mesolimbic pathway to look at the receptors. So say, give me a list of receptors. So patients who are using PCP, it exerts its effect primarily by targeting the Mesolimbic pathway. It's important to know the receptors on the Mesolimbic pathway so we can understand what medications or what tools we need to sort of stabilize this pathway. Mesolimbic pathway primarily utilizes dopamine receptors, I guess all of them. Also interact with other receptors. Okay, mu kappa delta and glutamate receptors, right? Dopamine and glutamate receptors. So we're going to use in this case, when they come in with psychosis and agitation and things like that, we need to use the dopaminergic agents to sort of block the activity in that pathway. And typically when you hear about patients with PCP, usually it's a bizarre history of, lifting the car off the ground or fighting 10 people or things like that. Superhuman stuff. So you can see how excessive glutaminergic activity leading to all this excitation is one of the reasons why the entire body's, the person being host is agitated, And so we definitely want to use the major the typical antipsychotics for that. Okay, next, let me see. I'm going to look at LSD. So remember,
Reload.
PCP is synthetic also. So let me look at the next one here is, let me see if I have any questions. Let me know if you have any questions about PCP before I go to LSD. Does anyone have any questions before I go to the next example? Let me see if I have any questions.
Mesolimbic matrix.
Okay, let's see. Okay, so let me go ahead and go to LSD. Okay. All right. Okay. Psychedelic exerts its effect by activating serotonin, also norepinephrine also. So I guess, okay, mechanism binding to serotonin receptors. Okay, LSD binds to the serotonin 5-HT2A receptors, which are primarily located in the cortex, hippocampus, and amygdala. I wonder why since it's located in amygdala, why all patients with LSD histories seem to be so unpredictable. I wonder because the receptors in the amygdala, activation of receptors. Upon binding, LSD activates the serotonin receptors, leading to release of serotonin and other neurotransmitters such as norepinephrine. The increased neurotransmitter activity disrupts the normal balance of brain chemistry, resulting in a psychedelic effect. Okay. See, very seldom I see visual hallucinations, but I typically see the visual hallucinations in deliriums, and I wonder if the LSD is producing a delirium here, and that's why we see the visual hallucinations. But however, hallucinations here, vivid hallucination. Now remember, vivid hallucinations really and auditory experiences could be deliriums. Altered consciousness, yeah. Emotion, cognitive function. Okay, all right. Let me see the structure of it. Okay. See, what is the treatments of LSD intoxication? Respiratory support, endotracheal intubation if needed, hypertension, tachycardia, hyperthermia. These seem to be different from like cocaine. Methamphetamines can have these hyperthermia, things like that also, but it's different. Okay, so this is the over the past few lectures, I had a chance to review all of the drugs of abuse and the impact that they have on this mesolimbic pathway. So when we see patients in the inpatient setting, we typically see them in withdrawals, and that's when we have to start treating at this point. Let me know if at this point it's 18 minutes. I didn't want to go too far in this, and I think that's all I wanted to say for those two substances. And let me know if there's any questions. If anyone has any questions, let me know. Let me see here. Okay, nice to see you, Doc. Okay, good to see you. Okay, great. Okay, let me see here first. Okay, T-Jam. How does PCP affect the mesolimbic pathway differently from LSD? See here. Let me show you here. me see here. This is the mesoreceptors. Yep, I went through it. Okay, let me see next question. Okay, next questions. Are hallucinations purely from the visual cortex, or is dopamine involved too? Yeah, I think all of these will have to come from that cortex. It's just dopamine, excessive amounts of dopamine can be associated with hallucinations, visual hallucinations, but I never really see them that much in the context of schizophrenia. I usually see visual hallucinations in the context of confusion or deliriums or drug intoxication like PCP, LSD, things like that. But very seldom do I see visual hallucinations associated with just schizophrenia. Next, see Max. Good to see you, Max. Max. Next. Okay, great. How does the Mesolimbic pathway contribute to LSD's hallucination versus PCP's dissociation? Good question. Good question. Their mechanism of action. The mechanism of action. Nice to see you, Doc. Hey, Maria. Okay, great. Next, here. Let's see here. Is the long-term psychological impact more dangerous than immediate high? I think so, because the immediate high could lead to brain cell death. And with that brain cell death, you get the inflammation and that inflammatory response that makes the blood-brain barrier porous. When the localized injuries create the porous blood-brain barrier, then everything comes into this central nervous system space. And how does all this equipment work with all this filthy, dirty stuff all around? So it does have an impact on the psychological dysfunction long term, because you lose the organs start to malfunction. So the hippocampus, the prefrontal cortex, and frontal lobe start to become impaired because of the damages. Okay. Any other question? If there's no other questions, it's 21 minutes. I think I can go ahead and sign out at 21 minutes if it's not any other questions. Okay, great. So no other questions. I'll see you guys later, and we'll pick up this discussion later. Okay, take care of yourself.